Thank you so much for the introduction. I'm going to have to update a couple things on my bio.
I was going to say, did you already get that award?
Yes, and I'm no longer the headache fellow. I'm on staff now at Mayo Clinic in Arizona.
Wonderful.
Which is
I feel
wonderful.
I feel like that presentation I've done a few times, and I'm glad that we'll change it for you.
No worries. And I put a little bit of an introduction here as well. Can everybody see and hear me okay and sees the PowerPoint?
Yes, looks great.
Okay. All right. So again, my name is Karissa Arca, and I'm going to be giving you a very kind of extensive overview of Guide to Migraine Disorders. It might be a little bit of a whirlwind. I've got a lot to talk about in a short period of time, but we'll definitely take any questions afterwards. So a little bit of an update. I'm currently an assistant professor of neurology at Mayo Clinic in Arizona, and I specialize in both headache and autonomic disorders. I have since transitioned my role on the board for Miles to Migraine to our current headache fellow, which is wonderful, and otherwise don't have any disclosures for today's talk. And then here's a picture of me and my family. I also have chronic migraine. My husband, based on just everything that he learns from me during residency and fellowship, actually diagnosed himself with episodic migraine. And fortunately, our pup here, Dobby, does not seem to have migraine. He's kind of our migraine support pup. So the objectives of today's talk are to define migraine disease and the stages of a migraine attack, to understand the appropriate language to describe migraine and its treatments, and to review the different types of migraine and treatment options. So, in the headache world, we have the International Classification of Headache Disorders, which is basically the diagnostic criteria for any headache disorder that you could think of. And so right here are the criteria that we use to make the diagnosis of migraine. So those include headache attacks lasting 4 to 72 hours, untreated or unsuccessfully treated. And then the head pain having at least 2 of the following characteristics, being unilateral or one-sided in location, tends to be a pulsating or stabbing quality, moderate to severe pain intensity, and causing avoidance of routine physical activities like just walking around your house, climbing stairs, etc. And then during that headache phase, it has to be accompanied by either nausea or vomiting or light and sound sensitivity. And I think as has already been mentioned today, there are people that have migraine 24/7, persistent migraine attack 24/7. And so this is really just kind of a guide for migraine, but certainly we make the diagnosis of migraine a little bit outside of this criteria as well. And so an important point to make is that migraine is a clinical diagnosis. There's no MRI scan that I can order that I can see migraine on. There are no labs to confirm migraine, but sometimes as a headache specialist, or maybe your neurologist or your other provider has ordered brain imaging in you, and that's usually to rule out other conditions that could be kind of mimicking migraine or maybe bringing on a similar headache phenotype. And so we usually do that based on certain red flag characteristics of the headache that you describe to us. And so before I get too far into migraine, I want to kind of go over the language that we use to frame migraine. And it's language that you've heard all throughout the various talks today. So I really don't kind of ever want to hear someone say, it's just a migraine. Migraine is a chronic neurologic disease, and migraine attacks can absolutely be debilitating. And kind of circling into the next point, you hear all of us saying migraine. And that's again highlighting that migraine is this chronic neurologic disease. And someone with migraine, whether you have a headache or not, you still have migraine. We don't call it migraines, just like you wouldn't call asthma asthmas or cancer cancers. Within the spectrum of migraine, we can then have acute migraine attacks. So that's a really kind of important point that I like to make. And then when we're talking about medications that are used for migraine, it's really important to frame the way we talk about the way that those medications have affected patients. And so instead of saying that the patient failed this medication, remember that medication failed the patient. It was either ineffective or not well tolerated because it caused side effects. So we're going to put the blame on the medication, not on the patient. And speaking of medications, many have probably heard the term medication overuse headache. That can happen when you're just trying to treat your migraine attacks, and that means using acute or as needed abortive medications. But when those are being used more than a couple of times per week, it can actually lead to a rebound cycle of headache and overall make your migraine pattern and migraine disease worse. Medication overuse headache can kind of put some of the blame on the patient when all they're trying to do is make themselves feel better. And so instead, I do prefer the words kind of medication adaptation headache or rebound headache. And then last, I think it's important for all of us, and I'm including myself, remember I have chronic migraine as well, to not refer to even each other as migraine sufferers or migraineurs. That's letting the disease kind of take a hold of our life. Instead, we are people that are simply living with migraine, living with a potentially debilitating neurologic disease. And so we're all really warriors, and we're migraine warriors. So when we kind of further classify migraine, there are two main subclassifications, either episodic migraine or chronic migraine. And I'll kind of talk about chronic migraine because if you don't fit in there, then you're usually episodic. And chronic migraine is defined as some type of headache for at least 15 days out of the month, at least 8 of those which meet criteria for a migraine attack. And this has to be going on for at least 3 months. So a lot of the patients that I see do have chronic migraine. And kind of one of the most important parts about making this distinction is if we can catch somebody that's in an episodic migraine pattern, we want to try to do everything we can to try to prevent that episodic migraine pattern from turning into a chronic migraine pattern. But again, because migraine is a neurologic disease, as much as we try to try to prevent these things, either through lifestyle, medications, etc., you know, everybody's disease is going to be different. And so no matter kind of as hard we might be trying to prevent that transition, in some people, they're going to develop chronic migraine. And so about 2% of the general population has chronic migraine. And in those with migraine, about 8% have chronic migraine. And those numbers might seem a little bit low, but remember that so many people have migraine worldwide. So we're actually talking about a lot of people here. And so I wanted to highlight some of the potentially modifiable risk factors to prevent episodic migraine from turning into chronic migraine. And so when I, as a headache doctor, identify somebody with a high baseline attack frequency of migraine, so migraine attacks occurring at least once per week, that's a person who should definitely benefit from a preventive medication to try to reduce the frequency and the severity of their migraine attacks. Similarly, somebody who's using acute medications very frequently, more than 2 or 3 times per week, that's another area where we really want to intervene with adequate preventive strategies to try to reduce that frequency and reduce the severity of the migraine attacks. Caffeine is a little bit of a double-edged sword because for a lot of people, caffeine may actually abort a migraine attack or may make you feel better during a migraine attack. But the kind of chronic overuse of caffeine could also lead to some of that kind of medication adaptation headache or rebound headache. I screen my patients for snoring as well because sometimes sleep apnea has gone unidentified for many years, and the treatment of sleep apnea can also significantly improve the migraine trajectory. And then finally, inadequate treatment of acute attacks can lead to the chronification of migraine. So having an acute or abortive medication that's effective and that really helps you to feel better or even headache migraine free within a couple of hours is really important, rather than having a migraine attack that's lasting days at a time. And I know that that's not always possible because we do have patients that have continuous migraine. And then unfortunately, there's a couple of non-modifiable risk factors. In general, we find that women tend to have more chronic migraine. Those with the feature of allodynia also tend to have more chronic migraine. And allodynia is the perception of pain from a non-painful stimulus. So I hear that in my patients when they describe, I can't even put my hair up into a ponytail, or brushing my hair in the morning is just so painful. Sometimes even it's the water from the shower kind of trickling on the head. None of these are supposed to be painful, but they're perceived as pain. And the allodynia doesn't always need to be in the head. It can even be in other parts of the body. Head injuries, if they happen, also tend to lead to a very kind of chronic migraine type picture that can be difficult to revert back. And then I put these last 3 in parentheses because I actually feel that these are modifiable risk factors. Things like depression, anxiety, comorbid pain disorder. I feel that all of these also warrant very aggressive treatment, just like we're going to aggressively treat migraine. And fortunately, some of the migraine treatments we use can have positive effects on depression and anxiety. Conversely, there are some medications we use that could worsen these. So keeping these other medical conditions in mind is extremely important for the overall treatment of migraine. So I wanted to review the stages of a migraine attack. And this is actually something I created back when I was a resident that I would show my patients when we were discussing migraine. And I've found it very helpful over the years. So highlighting first this red column, that's the actual migraine attack that we discussed the criteria for a couple of slides ago. We are going to call this kind of the headache phase, although understanding that not every migraine attack even has to have head pain associated with it. But so these are those characteristics of the kind of one-sided throbbing type headache, etc. But before that actual headache or migraine attack actually starts, people can start to feel unwell for days beforehand. Some of the most common symptoms that I hear my patients describe are fatigued, a lot of neck stiffness, kind of drowsiness, yawning, and food cravings are another big one. And there's kind of a lot of controversy actually in the migraine world. By listening to our food cravings and and eating certain foods, are we then triggering the migraine attack, or is that already the migraine attack in process? I kind of tend to think the latter, that we're kind of listening to our food cravings, but that migraine attack is already in process, and it's going to happen whether or not I eat that food that I'm craving. So after that kind of premonitory phase, there's a subset of patients that are going to experience migraine aura, and I'm going to go into a little bit more detail about migraine aura in a couple slides. But basically, migraine aura is a constellation of neurologic symptoms that can be visual, sensory, motor, and they evolve over a period of 5 to 60 minutes, generally before the headache attack starts. And then that leads into the migraine phase. Once that kind of headache migraine attack is done, maybe you aborted it successfully with medications, or maybe it just kind of burned itself out. A lot of people still feel unwell for 12 to 24 hours afterwards. A lot of my patients refer to this as the migraine hangover. But it can include a lot of kind of generalized fatigue and just kind of tiredness, still having a lot of that impaired concentration, irritability, and nausea. So I think that kind of understanding all of these phases can really help you to realize that even on the days where you're not having that head pain, you may still be in a migraine attack. And so, as I just alluded to, there's a couple of different types of migraine. There's migraine without aura, so we would just take that blue column out. Migraine with aura, and I'm going to talk to you about a couple of the different aura types. There's something called hemiplegic migraine that involves actually weakness on one side of the body associated with a migraine attack. Retinal migraine and vestibular migraine that I'm going to talk to you a little bit about. So visual aura is one of the aura types that I encounter in my patients probably most frequently. And it can be really scary if someone's never experienced a visual aura before. As I mentioned, the aura usually starts about an hour before the actual headache attack starts. And visual aura can consist of things like zigzag lines, rainbows, spots in the vision. Those spots can be bright, like some of these. Sometimes those spots are black. And in general, the migraine aura kind of tends to start on one side of the visual field, and then it gradually enlarges and gets bigger. And some people actually lose vision during a migraine aura. Because whatever that visual phenomena is actually takes over their whole visual field. And so I actually can remember some of the first times when I was in my training encountering migraine with visual aura was actually in patients in the emergency department, because it was their first time experiencing a visual aura, and understandably so, it was very scary. Which, like I mentioned, you might imagine if you've never had this before and didn't know what it was. And so, again, aura usually evolves over a period of 5 to 60 minutes. And the aura sensations tend to travel and spread. And I'll explain why they tend to travel and spread. We think that most likely the basis of aura is this process called cortical spreading depression. And really all that is that there's these chemical changes that are occurring in neurons that spread electric currents across the brain. So they tend to start in the back of the brain, and then they spread those electric currents towards the front of the brain. And so that's why we get some of the spreading of this neurologic phenomena. That's why the visual aura kind of tends to get bigger over time. That's why somebody with a sensory aura might start with the tingling or numbness in their hands, but it's going to spread over the arm over time, sometimes even spreading into the leg or into the face. And then I wanted to highlight a condition called vestibular migraine because I find that it goes undiagnosed a lot of times. And I think that that can be very frustrating for patients. And so very briefly, vestibular migraine consists of vestibular symptoms of moderate to severe intensity that last anywhere from 5 minutes to 72 hours. So what do I mean by vestibular symptoms? So our vestibular system in the body starts in the inner ear, and then that transmits information into our brainstem and into our cerebellum. And together, all of these things work together to help us understand our position relative to our environment. And so it helps us coordinate our movements, coordinate our walking, coordinate our eye movements. And so if something is off between the inner ear or between the brainstem and the cerebellum and our eye movements, that can cause what we call these vestibular symptoms. And so typically vestibular symptoms are described as dizziness and very often described as vertigo. And with vertigo, a lot of the time we think about it as room spinning, and it very well can be. But I want you to kind of think about vertigo as a sensation of movement that is not there. And so if somebody is experiencing vertigo, they may feel like their environment relative to them is moving, or maybe their environment is steady, but internally they feel that their body is moving, maybe like they're on a boat or something like that. So these kind of vertigo symptoms or vestibular symptoms can occur spontaneously without any trigger. Just like you or I are sitting here right now, it could just kind of pop up. Sometimes it's positional, so occurring after a change in your head movement or standing up. And then other times it can actually be visually induced. And I hear this very frequently, where if somebody walks into a large store, something like Walmart or Costco or Sam's Club, when you walk in, there's bright fluorescent lights, there's lots of aisles and shelves, there's people walking all over the place. It's this very visually stimulating environment, and that can actually trigger vertiginous or vertigo type symptoms. And so to make a diagnosis of vestibular migraine, someone does have to meet the criteria for migraine that we discussed previously. But a really important point to make is that these vestibular symptoms can occur with or without the headache or migraine. You do not have to be having an acute headache type migraine attack to be having a vestibular migraine attack. And so if you're thinking that this might be something that it could apply to you, for sure talk to your doctor about it, because it's also important to rule out other causes of dizziness. And so then on to migraine treatment. Just like with any other chronic disease or condition, it's important to modify your lifestyle. And I do think that sometimes lifestyle modification can be one of the hardest things to do. A couple of my colleagues actually published the Seeds for Success for migraine, and those include adequate sleep. That's going to vary for everybody. All of our bodies need a different amount of sleep. Regular exercise, 3 to 5 days per week. As you may imagine, if you're having an acute migraine attack, or if you're somebody that's always in a migraine attack, things like this can be particularly difficult. But there are resources out there. And I think, as was mentioned in one of the other talks, maybe it's just something like stretching and deep breathing that you can tolerate that day, and that's okay. Eating is really important. Missing meals or inadequate hydration are definitely triggers for migraine. And so some people with migraine may find that even just kind of grazing throughout the day might help prevent migraine attacks, prevent them from getting too hungry. Or just eating snacks in between your regular meals can be helpful. Keeping a headache diary is particularly important for the physician-patient relationship because by keeping something objective like a diary of your headache attacks, how severe they were, how they responded to your acute treatment, will really help you to be able to discuss migraine with your doctor in a very objective way, and can help lead to medication changes, other treatment changes, etc. And then, of course, modifying stress is helpful for any chronic disease. I wish we could avoid stress altogether, but knowing that that's impossible, there are things we can do, like working with cognitive behavioral therapists, mindfulness exercises, relaxation, biofeedback, that in the long term can overall reduce stress in the mind and stress in the body. And as far as lifestyle, I also put here avoidance of triggers. For some people, it becomes very clear that certain things are triggers. Maybe it's drinking wine, maybe it's only getting 5 hours of sleep, that type of thing. But I do want to emphasize that there doesn't have to be a trigger for migraine. A migraine attack can just come on out of the blue, regardless of how adherent you are to these seeds for success and other lifestyle changes that you've made. And so I really want to kind of shift the blame away from you and understand that that migraine disease just kind of has its own mind. And so briefly, when we're talking about treatment of migraine, there's two kind of major categories of treatment. There's what I call abortive treatment, which is your as-needed migraine medication that you take for an acute attack. That can range anywhere from just over-the-counter medicines like ibuprofen or acetaminophen. And for some people, those are effective. Other times, we're prescribing migraine-specific medications that I've listed the general categories here, or recommending neuromodulation devices. The goal with a good abortive treatment is that you feel significantly better or maybe even pain-free within a couple of hours of taking that medication. It should allow you to kind of get on with your day. And then we've got the category of preventive medications, and these can range anywhere from vitamins, which I call the nutraceuticals here, to other medications that we've borrowed from medication classes, things like antidepressants, antihypertensive medications, anticonvulsants, which may be helpful if we're treating things in addition to migraine, like maybe some of that anxiety or depression, etc. There are Botox injections. And then more recently, in the last couple of years, we now have access to what are called CGRP monoclonal antibodies, as well as the GPANTs that are now being used for prevention. And these are our first migraine-specific preventive agents. We've had to wait a long time to get our own migraine-specific preventive medications. And I'm optimistic for the future that we'll continue to kind of build on this and have more medications available for migraine. And again, neuromodulation can be used as a preventive. I did just want to highlight here some of these non-medication treatments like the neuromodulation devices. I'm not going to talk about these in detail, but they're something that you could look into further through the American Migraine Foundation or other good resources, and discuss them with your doctor if you would be a good candidate for something like a neuromodulation device that's using a non-medication option to treat your migraine attack. And then again, also emphasizing things like cognitive behavioral therapy and biofeedback. And that's the end of my whirlwind talk. I'll take any questions, I guess, if we have time.
That's great. Thank you so much for all that information. So we have a question. Can you experience several different types of migraine at different times? There's the question's from Laura. She feels like she's experienced several of them. She has chronic daily migraine.
Yeah, absolutely. I have patients that have migraine without aura, migraine with aura, that have vestibular migraine, just all in one patient. And so one migraine attack isn't necessarily going to behave like the others. So there could definitely be variety.
Okay, that's great to know. And do you have, if any of you have any questions, you can put them in the chat. I have one more. Do you have any tips for going to the ER? We know it's always so difficult when, I mean, most of us try to avoid the ER to begin with, but when we do go to the ER, do you have any tips for us on going to the ER?
Yeah. Actually, I'm in the process of helping one of my patients with this right now. But ask your headache doctor, your neurologist, or other provider for a letter that you can take with you to the emergency department, and a letter that says this is your diagnosis, this is your current acute treatments, these are your current preventive treatments. These are medications that maybe you've received in an IV form in the past that have helped break your migraine attack. If that isn't effective, maybe consider this, this, or this. I think that is something that can be really helpful. And I know a lot of my patients will avoid the emergency department at all costs because of the stigma that they've experienced in their experiences there.
Yes, 100%. And we're working on putting something together at Miles for Migraine in a program we're doing to give to the hospitals and the ER departments to teach them a little bit about migraine. So hopefully we can help everyone too. But that's wonderful. Thank you so much. Your presentation was fabulous, and we really appreciate your time.
Thanks for having me.
Yes, that was great. So having said that,